arousal level may have affects the emotional dysregulation and also reduce the cognitive abilities. When the person have cognitive ability is reduced, it may affect the attention disabilities and sensory reception sensitivity, working memory, and episodic memory deficits. That's why the child may not able to maintain the facial expression, recognition, for the autistic spectrum disorder. So coming to the literatures, it says that mindfulness relaxation and mindfulness body training is more enhancing the neuronal connectivity to improve the emotional recognition in children with autism spectrum disorder. Not only that, it also music regulation may also improve, especially the mellow music with the rhythm-based music with the low, slow tempo, that means 60 beats per minute, will enhances the child emotional regulation. So there are many studies has been conducted on emotional recognition interventions. What they said that it's to improve the maintain and motivation to improve the children, especially while we doing the emotional recognition, while we giving in the technology based, especially on animation, sound based interferences in the technology base, the child may have reinforced so that the child may improve the emotional recognition, especially on the facial recognitions. So it is more consistency and predictable learning more to improve the children with ASD. There are many studies has been conducted in emotional recognition, but still is unclear. So the purpose of this study is, since there is no study investigated both transference and maintenance effect on emotional recognition program, it's still unclear. So therefore, the study has been stated that the facial future and coach support can lead the long-term effect can be generalized to other social skills as well as the cognitive skills. My aim of my study is to develop and affect the emotional recognition memory training on social cognition in children with autism spectrum disorder. So this is the flow chart of my research procedures. So I will be doing a research on Saudi Arabia. So it has two phases. The first phase will be developing the emotion recognition memory training program. The second phase will be going on to providing the intervention. We'll do planning to do on the RCT studies with the 30 samples. With the 30 samples, we'll do the inclusion and exclusion criteria with the control group and experimental group. We have pre-test and also the post-test will be there. When I go for the first phase, it is to develop the emotional recognition training program. It is basic to identify the literatures from the what are the training can be given, how to develop this emotional recognition training program. And the second phase is going more working on the RCT. Using with the 30 samples, the training will be given for 10 minutes of self-relaxation, that is called deep breathing, and 10 minutes for slow body movement with rhythmic, mellow instrumental music, and 40 minutes for this emotional recognition with the technology-based training. So this is the rationale of my research, especially using with the CBT and using with the ES theories and also working memory theory, as well as with the DIM theories. So this is my theory. And this is the framework has been developed based on the literature base. This is the interventions has been developed based on the task 1-2 activities, and the task 2-9 activities has been given. So this is the child will be doing expression, will be developing basically on the technology based. So basically in the discussion part, so what we're going to do, we'll hide the background of the things so that the child started to focusing. So the child will enhancing to reduce the hyperarousal and also enhancing the facial expression. When it coming to the literatures and all the saying that the use of emotion control and the technology based intervention to teach the emotion recognition in people with ASD. So this research is need to be filled the gap, identify the previous review, the frame of the study of ER, MTP with coach support, and also emphasizes on the future, the facial feature to improve the treatment for children with ASD. So all this intervention will be conducting based on the content validity, and all the RCT will be going to be conducted. We are waiting for the ethical approval. Once we get it, the process will be started. Thank you so much for listening. And I would like to thank for my supervisor, Dr. Suprapon and Dr. Praya, and also Siriya. Thank you so much for listening.
Thank you, Smiley. So I saw 3 questions coming up already. We start from the person who raised the hand first, probably Ajahn Busaba, please.
Thank you. Thank you for your interesting talk. You mentioned about the emotional recognition is very interesting. I would like to know that is this associated between the emotion recognition with the physical activity in the ASD?
Yeah. So the studies has been, thank you so much for your questions, the valuable questions. And many studies, they are saying that emotional recognition is more affected to the autistic children. And they found that why it is affected because of the hyperarousal. So when they have hyperarousal, they may not able to focus. They may not able to recognize the person facial expression with a different expression like happy, sad, fear. And there are the basic 6 expressions they may not able to focus it. That's what the first phase our intervention is more focusing on. They make them to control the arousal level by giving the deep breathing training with the and also slow body movement with the 10 activities we're planning to give it. So the previous study, they have given only the separate intervention, but they not focus on combination interventions. So first we'll control the low arousal level and make them to relax it. And after that, we're planning to give it on the intervention based on the technology basis with using with the step by step. First, visual training will be given, and next one is auditory training, and third one is visual auditory training will be merged together, and finally we'll go for the generalizing training. So this is basically step by step process based on the dynamic interaction model we're planning to do it according to the transition phases.
Thank you. Next will be Ajahn Suripan. Ajahn Suripan, we cannot hear you.
Ajahn Chatchanok.
Okay. Ajahn Chatchanok, เชิญเลยค่ะ
Okay. So for your intervention treatment, do you consider to use 3D emotion or just only 2D emotion from the movie? Do you understand the question? I mean, the recognition comes from 3 dimension, not 2 dimension.
Yes, doctor. According to this autistic children, they may not able to focus immediately on the 3D dimension. So we've started our first week, we'll be working on very like animated video. We started to use it. So we'll cover all the backgrounds and only just animated videos. Like they may not able to focus on other area. And it must be every time when the child was focusing, the reward was given it. That's the first one they will be giving. After that, gradually we'll apply to the real life situations. So if they're giving a 3D dimension, they may not able to focus because too much of distraction the child may have it. So because they already have over aroused, they may not able to sit for a few minutes. So we'll start to control slowly, doctor.
Okay, thank you.
Thank you, doctor.
Final question from Ajahn Suripan.
Okay, what do you think in your framework, what factor that can affect the program?
So the first factor, it might enhances, they have to control the arousal level. That's the first part we plan to work on it. So they may have to sit and they have to have a deep breathing because that's the first part, and the body slow body movements. Once they emotional will start to come, then they started to focus. That's the first part. They may improve it. The second part is more using all the technology one. So first phase is more on relaxation phase. The second phase will be on technology base, and third phase more on realistic phase. They will try to apply in the real life situations. They will be interacting with the therapist and they interacting with the children about the facial expression. They will be recognizing about different types of facial expressions like happy face, sad face, and the sixth phase they will be doing it. So it's basically on the graduation, the transition phase, doctor. The first factor, it will be improved.
So any factor that will affect the program in your study? Did you consider that as well?
So that's what initially we'll try to exclude it, all the factors, especially the sensory over arousal, especially the auditory sensory will be over arousal, hypersensitivities, and also we will be excluding those conditions. Only the mild condition we start to use it. So only the mild one, we are not going to take the too much of hyper children, we're not going to take it first.
Okay.
So.
Okay, thank you.
Thank you, doctor.
Thank you, Smiley. If we have more time, I would like to ask you to give us an example of the music that you use with the children.
Yes.
But we ran out of time today, so thank you very much.
Thank you very much. Thank you so much.
We'll move on to actually the next department, the Department of Physical Therapy. So we have two PhD candidates from Physical Therapy Department. The first one is Nipaporn Wannaprom. Are you ready, Nipaporn?
Yes, I'm ready.
Yes. Would you make your slide a little bigger on the full screen?
Okay.
Yeah. Okay, I can see it. If you're ready, you may start.
Good afternoon, everyone. My name is Nipaporn Wannapom. Today, I would like to talk to you about my research study under the title of The Relevance of Scapular Dysfunction in Neck Pain, Clinical Features, Kinematics, and Muscle Activity. It's a good point to start with the conceptual framework of this study. Abnormal scapular position and motion, or scapular dysfunction, has been demonstrated in individuals with neck pain. Passive scapular corrections can be performed to identify the contribution of scapular dysfunction to neck pain. The majority of patients with neck pain had decreased pain and increased neck movement following passive scapular correction. However, no change in neck symptom was reported in some patients. This result may suggest that the scapular dysfunction is not necessary to be related to neck pain in all cases. So it is questions if there is any difference in characteristic between individuals with neck pain with related and unrelated to scapular dysfunction. Moreover, scapular kinematic and axial-scapular muscle activity are important to highlight the association of scapular dysfunction to neck pain. Evidence found the alteration of scapular kinematic and activity of cervical extensors and axial-scapular muscle in individuals with neck pain. However, these alterations might not be directly related to neck pain. It is questions if there are any difference in scapular kinematics and EMG activity between individuals with neck pain with related and unrelated to scapular dysfunction. So my study have been divided into 3 studies. For the study one aims to determine if there is any difference in neck pain and scapular dysfunctions characteristic between responder and non-responder to passive scapular correction. 144 participants were recruited. Scapular dysfunction and neck pain characteristic, cervical range of motion, and cervical joint dysfunction were measured for baseline measurement. The participants who have reduction in pain intensity more than 2 score and or increased cervical range of motion at least 7 degrees were grouped as responder. And after that, the baseline data were compared between groups. For study 2 aimed to measure scapular kinematic in individuals with neck pain with related, unrelated, and no scapular dysfunction compared with asymptomatic controls. In each group consisted of 29 participants. The motion analysis system was used to correct the scapular kinematic during unilateral arm elevation in scapular pain under 2 conditions, including without weight and with weight. The reflective marker attached on the participant were tagged and were reconstructed by the motion analysis software. After that, the motion analysis files were analyzed in specific software showing the movement of the scapula in degree. For study 3 aimed to measure EMG activity of neck extensors, upper trapezius, lower trapezius, and serratus anterior muscle during isometric tasks in individuals with neck pain with related, unrelated, and no scapular dysfunction compared with asymptomatic control. Each group consisted of 31 participants. The muscle activity were measured during unilateral shoulder isometric contraction at the 30 degree of shoulder abduction, 30 degree of shoulder flexion, and 30 degree of shoulder external rotation with a custom-built dynamometer device. And each task was performed at the 3 intensity of effort with a custom writing program. Start with the maximum voluntary contraction and After that, participants perform the submaximal contraction at 20% of MVC and 50% of MVC. The visual feedback gap and auditory feedback were given for the participant to serve as an indicator of the target fault. The finding in this study will enhance the understanding of clinical symptoms and signs of neck pain associated with scapular dysfunction, and subsequently, such knowledge will inform the optimal assessment and management of chronic idiopathic neck pain in clinical practice. Because of the situation of coronavirus, the data collections was delayed about 6 months, and currently, our study have recently completed the data collection, and they are on the process of data management and analysis. The study was supported by the National Research Council of Thailand and Royal Golden Jubilee PhD program. Thank you for your attention. If you have any questions, please feel free to ask me.
Thank you, Nipaporn. So that sound is coming from your video, right?
Yes.
Okay. Yes, already there are some questions. Dinwara, is I pronouncing it right? Yeah, you can ask.
Yes. Could you please explain more about the possible mechanism of improvement of neck pain and neck movement by passive scapular correction?
Okay, thank you for your question. Based on the anatomy, the cervical spine and scapular regions are linked to each other to the axioscapular muscle, including the upper trapezius muscle and levator scapulae muscle. So, abnormal scapular position and motion can induce compressive loading on the cervical spine, leading to neck pain. And when the scapula was manually corrected to nearly the normal scapular position, it can reduce the passive state on the disc muscle and leading to the reduced compressive loading on the cervical spine. And finally, it can improve the neck movement and neck pain when the perform the passive scapular corrections. Okay.
Okay. Ajahn Busaba has a question.
Yeah, thank you for your interesting talk, Mrs. Nipaporn.
Thank you.
I would like to ask you a simple question. Now is the data collection still ongoing, right?
The data collection have been recently completed.
Oh, and did you analyze any data?
For the main study, I don't have any analyze or any results, but I have the result of the preliminary reliability study of the scapular dysfunction test and passive scapular correction test.
And I would like to ask about the main result. Go with your hypothesis or not?
Unfortunately, we have to do this again in the next 3 months also, so we know the answer.
Yeah,
yes.
I think she saw some of the data during the data collection, so she might be safe that go along with your hypothesis, or how about it?
For the study one, based on the result of the reliability, I think there is the difference in the scapular dysfunction type between the patient with neck pain related and unrelated to scapular dysfunction. I see the patient with neck pain related scapular dysfunction have the scapular downward rotation more than the patient with unrelated scapular dysfunction.
Yeah. Okay. Thank you. It looks good.
อาจารย์ชัดชัยค่ะเชิญค่ะ
For analysis of scapular motion, would it rely also on the muscle size? Do you have to classify the population of the subjects by the size of the muscle?
For the excuse me, Professor, do you mean the scapular kinematic measurement?
Yeah. Do you have to classify the subjects relying on their muscle size as well. The
Um,
muscle
On the
of
left,
every, yeah.
on the left, or on the right, and also if they're right-handed and left-handed, you mean as well? Yeah. Is that
Okay,
clear?
thank you for your question. In this study, I measure the scapular kinematic on the painful side of neck pain. Yes, I didn't control the dominant or non-dominant side, but the participant in this study have to the neck pain with the scapular dysfunction, and
So you rule out the factors of muscle size, right?
no, I did not control the muscle size in this study. Yes.
But you recruit every single side that has a pain, right?
Yes.
So it may be include from both sides, right? If they have the pain at both sides.
In this study, they include only the participant with unilateral neck pain.
Oh, okay. Thank you. Just one side for each subject. Okay.
Are there any more questions for Nipaporn? Okay. Thank you, Nipaporn. We will move on to the next speaker. Yeah. The next speaker is Shamima Islam Nipa. Nipa, are you ready?
Yes, I'm ready. I'm going to share my slides.
Yes. What time is it there, Nipa?
1:25.
Okay. So you after us. We are 2:20.
Yeah. Why I'm not getting my slides?
Yeah.
Okay. Give me some time.
So you hit the share screen button on the bottom.
Yeah.
Middle.
Yeah. I have done this, but I have to find my slides. Sorry for the delay.
No problem. We have 70 people here joining us now. So I hope everyone's still awake. You didn't eat too much lunch, right? Ajahn Busaba clicking the reaction. So if you would like to participate with the reaction, there's a button on the bottom of your screen. You can always give reaction to the speaker. If you agree, if you are happy, if you would like to give them encouragement. Would this work, Nipa?
Yes, I'm doing work on it. So can you share my screen now?
Yes, now we see your screen.
Okay, thank you.
The PowerPoint is coming.
Can you share my slides?
I see the folders, but I don't see the PowerPoint yet.
Okay. Okay. Can you see it now?
Yes.
Okay. Thank you.
Your time start now. You ready?
Before that, I would like to move my slides. Okay. Thank you so much.
Perfect.
Okay.
Now you may start.
Yeah. Thank you so much. Myself, Shamima Islam Nipa, PhD candidate, Biomedical Science, Faculty of Associated Medical Sciences, Chiang Mai University, Thailand. And my advisor is Dr. Thenialak Sribunria. The title with which we have done our PhD thesis is Effects of Pelvic Floor Muscle Exercise, Combined with Core Stability Exercise among Women with Stress Urinary Incontinence following treatment of non-specific chronic low back pain. Urinary incontinence is a new problematic epidemic in the 21st century, which most commonly affects the women, and it can affect all ages women. International Continence Society defined the urinary incontinence as an involuntary leakage of urine. There was a study regarding the prevalence of urinary incontinence among the low back pain in Bangladesh, and it stated that about 68.4% low back pain women are suffering with the urinary incontinence. Furthermore, previous studies found a highly clinical correlation with the urinary incontinence along with the low back pain, and it stated that low back pain women are at double risk to suffer with the urinary incontinence. There are mainly three types of urinary incontinence, which are stress urinary incontinence, arch, and mixed urinary incontinence. Among the three types of urinary incontinence, stress is the most prevalent type of urinary incontinence. Pathophysiology. We know that the core muscles are composed of the pelvic floor muscle, multifidus, erectrospinae, diaphragm, internal and external oblique abdominis, and rectus abdominis. Pelvic floor muscle form the base of the core muscles. So both the core muscles and pelvic floor muscles are interdependent with each other. If any of the reasons these muscles are weakened or damaged, then their coordinated activities will be hampered and leads to urinary incontinence. The rationale of the study, previously a lot of studies stated that pelvic floor muscle exercise should be considered as a first-line treatment approach for the management of urinary incontinence. Nevertheless, not enough information on effective intervention regarding the urinary incontinence in respect of chronic low back pain only. Therefore, the present study comprises with the purpose of two sub-studies, whereas the purpose of the study one was to translate and verify the psychometric properties of the diagnostic questionnaire for urinary incontinence and incontinence severity index questionnaire. Whereas the purpose of the study 2 was to determine the combined effects of core stability exercise along the pelvic floor exercise in comparison to the pelvic floor muscle exercise alone among the stress urinary incontinent women who are suffering with their chronic low back pain. The study 1 administered, adapted, and validated of the QID and ISI questionnaire into the Bengali language with 47 respondents for the test retest reliability, including those women who are age range 18 to 60 years of age, having urinary incontinence with pad weight greater than 2 grams, and who are willing to participate and ability to understand the Bengali language. To do that, the study followed the scientific process of translation and cross-cultural adaptation process, including forward translation, backward translation, pre-testing of the pre-final version of the questionnaire, and the final version had gone through the psychometric properties testing of the questionnaire, including content validity, internal consistency, and test retest reliability of both the questionnaires. The results of the study 1 stated that both the QID and ISI questionnaire is highly reliable and valid in considering the convex alpha value greater than 0.7 and intra-class correlation greater than 0.8. The QID questionnaire has been previously translated into the Malaya, Chinese, and Thai language, which stated the similar findings with satisfied level of validity and reliability. Furthermore, incontinence severity index questionnaire obtained the highest recommendation from 2nd and 3rd International Continence Society. The study 2 administered by a blinded assessor throughout the stratified randomized control trial with age range 18 to 60 years of age and pad weight greater than 2 grams. The study conducted at the Center for the Rehabilitation of the Paralyzed in Bangladesh among the low back pain women who are suffering with the urinary incontinence. The primary outcome of this study considered the volume and frequency of urinary incontinence. Secondary outcome considered the quality of life of urinary incontinence. The volume measured by 1 hour pad test and frequency measured by Bengali ISI questionnaire, quality of life measured by King's Health questionnaire. So the experimental procedure followed the inclusion and exclusion criteria, random allocation of the respondents, and 1 blinded therapist do the assessment at 1st to 4th week, 12th week of the intervention program. The findings of the study stated that the amount and frequency of urinary incontinence significantly decreased after 12 weeks of the intervention, more in the experimental group than the control group, considering the p-value 0.004 and 0.014 respectively. The secondary outcomes also much more improved in the experimental group than the control group. The previous studies findings also support the present study, and it stated that after 12 weeks of abdominal muscle program significantly superior to the pelvic floor muscle treatment. An intention to treat analysis of the study also found the similar findings. About 84% respondents of experimental group cured from their urinary incontinence. So in conclusion, we can say both the questionnaires are highly valid and reliable for the cultural context and the Bangladesh, and the objective cure of frequency and amount is significantly reduced in the combined intervention group than in the pelvic floor muscle training only. Some parts of the studies already published in the several Scopus Index journals. And thank you so much for your attention to my presentation.
Thank you, Nipa. Just right on time. And also, we're wondering if you have a lot of traffic outside your windows.
Sorry for that. My house is just beside the main road. That's why. Sorry for that.
Yes, no problem. Ajahn Busaba has a question.
Thank you, Nipa, and congratulations for your already descent, right?
Yeah, thank you so much.
Okay. I would like to know that you do the RCT about the urinary incontinence, and
Yes.
could you explain more about how you interpret or control the daily activity of the participant in each group? I think maybe they have a different activity, like some people have a job different job, different activity, or different some factors that you be infer to the result. So how you control that?
Thank you so much for your valuable question. For the experimental procedure, for the time I couldn't describe elaborately. Right now, I'd like to describe more. At first, when the patients are calm, the respondents are screened by the quick questionnaire to assure that they suffer only the stress urinary incontinence, but not the urge or mixed urinary incontinence. When they assure that yes, they have stress, then to confirm the diagnosis, they have gone through 1 hour pad test. If the pad weight greater than 2 grams of any respondents, then they are included in the study. Followed by the study set up some inclusion and exclusion criteria, such as the low back pain must be greater than 3 months, because the study considered the chronic low back pain, and who had completed the study for at least 1 month ago, or completed the physiotherapy intervention at least 1 month ago, because therapeutic intervention parallelly might influence the findings of the study, because different therapists might give different intervention at the same time. So that's why. Furthermore, when the after that the 50 respondents had been included, then they are randomized into 2 groups by the computer generated random number with the opaque sealed envelopes, which had done by a blinded third person who was not involved in the research and doesn't know anything about the study. She has just done this divided them into the 2 groups. So we can assume that it would reduce the biasness towards the intervention and the control group. Beside those, the analysis of the results, we have found the baseline similarity. Most of the women who came in our institution in Bangladesh even are housewives. The majority of the respondents are housewives, and their level of education, majority respondents of secondary level of education, is mean age was the middle aged women, or the most commonly we have found 45 years age. And the other variables that we have measured in the baseline, there is no significant difference in any of the variables of the baseline characteristics of the experimental and the control group. So I think that in this way we can control the confounding factors that might affect the treatment outcome.
Thank you, Nipa. We probably have
May I
time
ask
for
a question?
Yeah. Yes, please. For more question.
I wonder whether you can recommend a core stability exercise for women in general. Thank you.
Thank you so much, Professor, for your question. In general, yes, previously it has been found and it is established that pelvic floor muscle exercise significantly effective in any other treatments rather than any other treatments of the urinary incontinence. Some modalities, even biofeedback, electromagnetic biofeedback therapies also. So I think that this combined intervention is has given a better outcome, that not only the pelvic floor muscle exercise is sufficient, or we can do a new start with the core stability exercise, because we have chosen very simple core stability exercise, not the advanced level of exercise, which will be more suitable to do for the women who can't ignore, or they might not feel a lot of difficulties to do the exercise. So I think if they would find their benefits and sufferings are improving day by day, they will be able to do the exercise. So in that case, we can try to better start of core stability as well.
Thank you.
Thank you, Nipa. I think it's time for one more question from Ajahn Suripan. Ajahn Suripan, we cannot hear you.
Sorry.
Okay, yeah, we can hear you now.
Your presentation, how could you be sure that the participant perform the exercise correctly? And what is the adherence rate for the exercise program?
Thank you so much, Professor, for your question. At each week of the intervention program, blinded assessor has conducted an objective assessment of all the respondents by using the objective measurement tool